everybody. I think we're going to get started. People will probably trickle in, but I want to make sure we have enough time so that we can have time at the end for questions. So I am Dr. Mary Ellen Crowley, and I have a practice in Lexington and work here at the hospital over the Pavilion program. And I'm glad you guys could all come tonight, and I hope you have a good discussion. I'm going to present mostly on the combined treatment of borderline personality disorder and various eating disorders. I think it's a really important topic at the hospital because a lot of the traditional treatments for eating disorders don't work as well when they're combined with the treatment for BPD. There's really a very specific treatment that works well, and I think tonight we'll talk a lot about the differences. And if you're in treatment and thinking about, am I in the right treatment, I think it's important to look at all the elements and make sure you're getting what you need. So, without further ado, we're going to talk about a couple things. We're going to talk about how common the overlap is of borderline personality disorder and various eating disorders. I'm going to talk about anorexia, I'm going to talk about bulimia, and I'm going to talk about binge eating disorder and look at some of the overlap. I'm going to talk about some of the assessment differences, what are really important things to look for, and how you might differ if you're doing an assessment with somebody that has BPD and an eating disorder, as opposed to somebody that just has an eating disorder. There's some other things to look at. Same with treatment, some of the differences that are important, and the outcome differences too. And I'll finish up with some case material examples of just kind of anonymous quotes that I think capture some of the ways in which tailoring the treatment becomes so important when there's a lot of double meaning involved with the symptoms and how it's important to look at both pieces. We're going to talk a lot about the relationship in therapy because it's so important to get that right in this combined treatment. How common is the overlap? Let's start with that. So BPD and anorexia overlap 20 to 33%, with the highest percentage being anorexics who are the subtype of binge purge. And what does that mean? So anorexia, actually, let me put up the criteria because I think that got, yeah. Let's start with just the criteria for anorexia first, just in case anybody is curious about it. So the hallmark criteria is really failure or inability to maintain a body weight that's normal, in particular to go below 85% of ideal body weight. And that number was picked because a lot of medical complications can happen around that point, and it becomes a problem in and of itself. In the DSM-4, we used to have as part of the criteria a loss of menses, but that's been taken out because we've seen a lot of young women that have very low weight and their body may or may not respond in that way by having an absence of menses. So I am glad for that change in the criteria because a lot of people weren't in this category for a silly reason. It's mostly intense fear of weight gain despite being underweight, so a real distortion around body image, and an undue influence on the general self-esteem where the weight is. And then the subtypes, restricting type is the folks that just diet and exercise but don't do any binging, purging, or other type of compensatory behavior. So things such as using laxatives, diuretics, purging, enemas, other things, other medications that might be used. And so we're going to talk a lot about the binging, purging subtype because we see more overlap with BPD in that subtype. While we're going over criteria, I'll actually mention a little bit about binge eating disorder and bulimia just to make the distinctions up front. So folks coming in with binge eating disorder, which is a new addition to the DSM-5, by the way, it used to be embedded in a category called eating disorder not otherwise specified, which wasn't that useful because it really is its own entity. So people in this subgroup are typically having recurrent episodes of binge eating, which is defined as eating in a short period of time or discrete period of time, like 2 hours or less, an amount of food that would be substantially larger than normal and is marked by a real experience of loss of control while it's happening. People in this group typically report eating rapidly, often eating alone because they're ashamed, a lot of guilt and distress about the behavior, and binge episodes that are happening when they're not hungry. So no compensatory behaviors in this group to get rid of or undo the binging, but a deep sense of shame and guilt is there. Bulimia. So again, the reoccurrent episodes of binging at least once a week for 3 months. And I gave you the definition of how the DSM looks at binge episodes, so I'll go through that again. A lot of reoccurrent inappropriate compensatory behaviors to prevent weight gain or undo a binge, fasting, vomiting, laxatives, diuretics, medications, excessive exercise, at least one of those happening at least once a week. Same kind of body image disturbance and an undue influence of weight and shape on the general self-esteem or general evaluation. And the disturbance doesn't occur exclusively during an episode of anorexia. So the hallmark difference is an episode of anorexia has that 85% or below 85% of ideal body weight. So, all right, so that gives us a context. So keep those three sort of categories in mind as we talk about some of this other stuff. So the overlap, 20 to 33%, with the highest percentage being the overlap between anorexics in the binge-purge subtype and BPD. And then for bulimia and BPD, overlap of 16 to 38%. Obviously, there are a lot of studies, so I'm just using aggregate kind of averages. And then BPD and binge eating disorder, approximately about 14 to 15% in most studies.
For assessment differences, so I think one of the most important things is the overlap in symptoms. So semi-starvation, which can happen with anorexics, often looks like when people are restricting their food intake, a lot of moodiness, irritability, apathy, increased depression, anxiety, and a lot of sleep irregularities. Does that sound familiar for other traits of BPD? It sure does. So one of the things that is really important with these assessments is understanding what's causing what and what's causing the dysregulation and having a good evaluation. And it might mean that if the person is doing a lot of restriction, that has to become a little bit of a priority to first get normalized if it's causing a lot of these symptoms. Very important. Increased rates of substance abuse. I put ED, BPD just for simplicity, but I'm basically talking about anybody who has those shared diagnoses. Increased rates of substance abuse requires a really good screening in the relationship between weight, eating, and drug use. So for example, if I screen someone who thinks they might have an eating disorder, but they have a bunch of other impulse control behaviors being around substance abuse, we might find out that they've been using cocaine and they have lost a lot of weight and then gained a bunch of weight, and they're disturbed by that, but that maybe the primary thing that's going on is substance abuse. It's the same with marijuana. If somebody's binge eating and they don't tell me that they're doing that in the context of using marijuana, it changes things. So I think all these become really important because of the significance of multiple self-harm behaviors that are going on for folks to really understand how they connect and how they relate, but also how they're separate and sometimes require separate treatments or different priorities. Sometimes the treatment has to shift and flex to prioritize the eating disorder or to prioritize suicidality or to prioritize substance abuse. And it's very important, I think, to do that kind of ongoing assessment. Increased rates of laxative abuse and purging in this population, that requires a really different kind of evaluation too, in that they produce their own sets of problems, laxative abuse, and a good medical screen is important. So sometimes I meet clinicians that ask me to do an evaluation and they will say, well, the patient is normal weight, but she's doing some of these behaviors and I've just understood or talked about the behaviors in the context of the BPD. And we realize, well, okay, but these things are important to actually check out in their own right for medical reasons and to understand what they're doing. So those kind of screening and assessment differences become important. Also the implication for changing levels of care. So if there's a patient who has a dual diagnosis, and they are maybe doing some bulimic behaviors and they're cutting and they get suicidal, we may decide on an inpatient hospitalization that wouldn't happen if that person didn't have kind of the whole host or rubric of self-harm behaviors going on. They have multiple ones going on. Sometimes we have to increase the level of care that we wouldn't do if it was just the eating disorder in isolation. So it does make a big difference to be assessing those things and understand, are we at the right level of care for this person? Critical to understand the function of symptoms. So I just put a couple of examples. Very common themes when we do a functional analysis and trying to understand why the person got these symptoms going. Some common ones that come up for folks with BPD and eating disorders: control themes, relationship communication themes, and identity issues. Those are probably the top three. So I'm going to take each one and talk a little bit about it. So the obvious connection between controlling body shape and size, to manage it, to do that, to manage some loss of control in other areas. So what are the loss of control elements? Difficulty with regulating emotion, difficulty with impulse control or ceasing other self-injurious behaviors. That's what SID is. So we often see a trade-off. Somebody's getting sober, they're not using drugs, and they're managing instead to do some of the eating disorder behaviors, and there's been a trade-off or replacement. Difficulty adapting to change, loss, and transition. So these are themes that we see with folks in the BPD population, and we see them in the eating disorder population too, but they have to be managed relationally in this population, which is very, very important. Eating disorder symptoms can serve to also regulate distance in relationships. So one example would be to elicit nurturance from a partner or a friend. And another would be to actually push others away, to isolate with the eating disorder, get involved in it, and push folks away. But sometimes it's an attempt to control the attachment figure or affect the attachment figure, or to communicate feelings without words. So this is a really big one, and it becomes very important. So DBT, being a primary treatment for borderline personality disorder, focuses on this a lot, right? How are you communicating? Are you communicating assertively? You know, what are your needs? Are you acting it out with behavior? Do you have a right to assert your needs and feelings? And so this becomes very central. Identity issues. So the eating disorder diagnosis can, for some people, be the identity they don't have in another way, you know, kind of a badge of honor, a badge of strength. Some people talk about feeling like they have it's sort of like membership in a club of people that are doing the same behaviors. And when folks with BPD are talking about a lack of sense of self or difficulty with identity issues, it can be sometimes appealing to fold into this slot. And so that's got to be a big focus of treatment when you have somebody with both diagnoses. Sometimes people will talk about these issues also being an attempt to ground themselves when they feel anchorless around identity, when they feel as if they don't know who they are and they don't know any other ways internally to ground themselves. So maybe they grounded themselves externally with relationships, and when the relationships aren't there, this can sometimes take its place. So I'm going to move on to talking a little bit about treatment differences now, and mainly because I think a lot of the research that's been done on CBT and eating disorders, they've used populations that typically are non-personality disorder populations. And so some of the results of the 20 to 25 session CBT trials on anorexia, bulimia, the success they have, they often don't have a little asterisk under their findings, which is that we screened out everybody who had any other diagnosis that could complicate the situation. And they should, because most of us in graduate school learning these treatments come to a place like McLean for training and realize really quickly they're insufficient. And I think for this population in particular, DBT has such good results because it looks at the relationship and it understands that the relationship between the therapist and the patient is important in illustrating all the skills, and that the therapist is not just a teacher or an instructor, but engaged and involved in this treatment, and that the dynamics between them can be useful to look at too. Interpersonal therapy, or IPT, does the same thing. It uses a relational model. It still involves some skills, but it really allows people to talk about the relationship in the room and how the things that come up with the therapist represent things that come up in their outside relationships too, with friends and family members and loved ones. I think some other treatment differences really need more sessions with the ED-BPD population to have success. Skills training alone without a special emphasis on relationships doesn't really work. And the overall duration of treatment needs to be longer. So typically the intensity of the treatment is greater. So more sessions and longer duration to have some of the same outcomes in terms of symptom reduction. And that's important because I think a lot of those initial studies that had great results for 25 or 30 sessions with CBT were really not these folks. So it's important. Let's see what else. So I was just going through some of the skills data and looking at some of the ones that are most helpful for the ED-BPD population. So behavioral activities that contraindicate negative arousal states. So relaxation strategies, things that kind of take that dysregulation and manage it behaviorally. Group therapy format is really, really helpful. And in fact, the research on people with eating disorders without BPD, and you look at the combined diagnoses, group therapy becomes more important. The social aspect of group therapy is very, very useful. So typically we want to include that. Cognitive restructuring of thoughts related to affective states. This becomes one of the most important skills for this population. How do you talk to yourself about the affective experiences? Is it okay that I have them? Do I have to act on them? Am I ashamed? The talk around that becomes critical. When I go through some case examples at the end, some quotes, I think you'll see that illustrated. Looking at attachment patterns, boundaries, and communication patterns and relationships becomes really important. I was talking about that a little bit before around assertiveness, but also conflict avoidance is a big issue. More structure is needed in the treatment, and I think partly contracts can be useful in this way. But there are often multiple areas of instability or multiple self-injurious behaviors, and so it's useful to put it in a context and have a sort of a clear boundary around the treatment of when would you go to the next level of care. If you're restricting and you lose this much weight, do we do talk therapy? Do we stop at this point? Do we ask you to go to the next level if you're going to stay in treatment with me? Not dissimilar to what happens around contracting for suicidal ideation. But it's really just as important because some of the medical indicators will tell us that at very low weights, the medications aren't working. And at very low weights, people's sleep is really dysregulated. And so it becomes just as important if we're treating depression, anxiety, BPD, and an eating disorder to be clear about those levels of care and what the priority is. Prioritization, and we just kind of talked about. Target behaviors for modification, this becomes really important, and they change over time. So restriction might be, a level 3 issue, and someone's really trying first to have safety and trying to manage being sober, and then all of a sudden this starts to become a bigger issue, and they start dropping weight, and they need it to be more of a focus, and we have to kind of see where it goes. It's very common that people make that switch when some of the higher order stuff calms down. But to stay flexible is really the critical thing as a clinician. The highest priority symptoms obviously might require hospitalization. I was talking about that earlier. More ambivalence. So eating disorders are often described as egosyntonic in that people often will see them as part of their identity, sometimes want to hold on to them, and so there's more ambivalence about giving them up than some other symptoms. And so we see that even at higher levels in the BPD population. And one theory is that the dysregulation emotionally is higher, and so they get used to using these behaviors potentially at a younger age, and they get harder to get rid of. So idealization and devaluation and therapeutic relationship is also important to talk about as a major difference in the treatment from somebody who has just an eating disorder versus adding the personality disorder. Some outcome differences. These aren't going to surprise you based on some of what we talked about already, but Some more negative outcomes when you're looking at just CBT treatment, so 2 years and 5 years post, both in the group format and individual format, more negative outcomes. At the 1 year post CBT individual treatment, in terms of holding on to full diagnostic criteria, 62% of the ED BPD patients in the study still met full criteria, at the follow-up time and at 1 year follow-up, as opposed to just 21% of the patients that came in with just an eating disorder. So it's a big difference, and it's, I think, important and highlights why CBT on its own doesn't work very well for this population. Lower levels of engagement, I think that has to do with the fact that CBT doesn't prioritize the therapeutic relationship as much. You're sort of a teacher and you're in a stance with somebody where they're just they're learning about themselves and they're becoming well-versed in using skills, but there's not a lot of discussion about the relationship with the therapist. It's not seen as, in and of itself, part of the cure, so to speak. And so it doesn't work as well in this population. Adding IPT and DBT helps a lot, and that is now, sort of more of the recommended path. Early intervention obviously yields better outcomes. That's probably true for everybody, but in this population it's especially important because it's typically clear that if there are a bunch of self-injurious behaviors going on, this one takes the last priority. So it typically sticks and it's in place for years before it ever gets on the docket for treatment. And so that I think is part of the story with some of the outcomes that we see. It's a complicated course of recovery. Typically in the research you see more sort of mixed results, not as many percentage of folks in the full remission or complete recovery category. So the numbers for anorexia, for example, in the eating disorder population are typically like 30-30 and the rest. And so you have kind of a split of people that are having episodes occasionally, people that are chronic and just really never remitting any of the symptoms, and then people that are in remission. And you see those numbers shift some more when you overlay some of the BPD data on it. So more people in the chronic condition, for example, it's harder. This longer term treatment, I think, really does help. That's part of the story. So I just want to share some case material because I was thinking this might be most interesting to talk about too. So these are just things I hear often from folks as they're trying to describe their experience. And I went through and just tried to illustrate with binge eating, with purging, some restrictions, some of these behaviors, how it comes together. That people are talking about their body, but they're also talking about relationships sometimes, or they're talking about some of the other relational symptoms that are part of the BPD complex. So I want to escape from these thoughts and feelings, wanting to numb out or unplug. So in terms of emotional dysregulation, this makes a lot of sense from a BPD perspective. It also makes a lot of sense when people are having negative thoughts about their body and feeling barraged by those and wanting an escape. Multifaceted. I want to feel comforted by the food when I'm lonely. So a lot of people outside of relationships talking about a setup for a binge that includes taking the phone off the receiver or turning the phone off, or closing the blinds, not letting the outside world in, but the experience sounds a lot like what this person said, which is that it's a comfort to me. I don't have a person to do that right now, and this is going to be the thing that is replacing that. Some people are really able to talk about this when they get interrupted, when they've decided to check out, numb out, and they get surprised or interrupted, sort of what it feels like, the intrusion it feels like. It's interesting. Can never get enough food in. I feel panicked that I won't get what I need. And some people label this as getting enough nutrients when they're really digging about what that means, when it's not about physical hunger. They know they can meet their physical hunger needs. They start to talk about not feeling like they ever got the nutrients they needed, or that they can't get enough of their needs are too big. They're not going to get met, and they feel panicked about that. And sometimes it comes out in the experience of binging in this way, in the way that they talk about that panic. When he sees me binge, he knows I'm in about space. He's often more attentive the next morning, checks in with me, or is just less critical. So this is a woman who was having a really hard time with direct communication to her husband and talking about the fact that she did not feel attended to, and when she felt attended to, it was often in a critical fashion, just to kind of pick. And so the behavior really became reinforced because her husband would sort of change in his response to her, and it was her only way to communicate to him that she needed him to be more attentive and tune in. So there's just a couple. I think I have one more. Yeah, so this one was related to restriction and some things I have heard pretty commonly over the years. I want to be hollow shell, feel nothing. It seems easier that way. So again, coming from a place of a lot of emotional dysregulation or just a desire to move away from being sensitive or having emotions, sometimes restriction is a path that people choose to try to numb out. When I'm thin and fragile, people are careful with me. They see my pain. I don't have to tell them about it. So again, having trouble communicating and the pain to others, having a body experience that gets people to treat them differently and to know they're in pain. The only time I got the nurturance I wanted and needed as a child was when I was ill. I don't feel I deserve it any other time. This is a powerful one with eating disorders, that some people have had other medical experiences, whether it be a period of sickness or another medical condition. It's not uncommon to have overlap with other medical conditions. And sometimes they felt good and that extra nurturance finally felt right. And they're trying to recreate that sometimes. They don't know how to express what they need. They sometimes act about this way. I want me and my needs and my emotions to take up less space. A lot of people talk about this, so they're talking about a body thing, being thinner, taking up less space, but they're also talking about the bigness of their emotion and attachment stuff and feeling like they would like to somehow whittle that down. If I don't stay thin and pretty, I won't be lovable. This is a really common eating disorder experience and thought, but certainly one that BPD folks talk about feeling defective, and maybe if I get my appearance just right, maybe if I can get my weight just right, I'll be less defective. I will be more appealing to others. I won't be abandoned. I'll be loved. So those themes kind of come out often. The last one on here, my emotional sensitivity makes me feel weak. I want to kill it off with starving sometimes. So the idea that they want to just take pieces of themselves, split off the pieces they don't like. And if the piece they don't like is being sensitive and feeling things intensely, sometimes the restriction becomes a way to try to kill it off. By the way, this sometimes is used because it feels effective. When people are restricting and their bodies kind of go to the real basics, when they start dropping weight, they do feel numb. Feeling these intense emotions, they do actually start to feel very flat, and the biology of restriction matches right up with that. So it's powerful. Just a couple more on function of purging and other compensatory behaviors. This can be for folks who don't purge. A lot of times people excessively exercise to undo a binge, or they might just excessively exercise in the context of anorexia. Laxative use, diet pill use, this sort of thing. I need to undo all my bad behavior, my impulsive binges, bad decisions. It's a reset button. So people sometimes come to see the need for the reset button emotionally too. So they start purging outside of the context of a binge. It just feels good to have this release that they've become, to associate with a release of emotions or a calming down, a compulsion just to do it, to undo something. And it started maybe with undoing a binge, and sometimes it ends up just actually undoing emotions. So people start purging when they're anxious, and they start purging when they, feel highly dysregulated as a way to almost ground and deal with it. Purging feels like getting rid of all the bad feelings all at once. It's a release of guilt. So that's sort of what I just said. Makes me feel alive is an interesting point in terms of grounding. And some people do talk about that in the same way they talk about cutting. That the purge itself, it's kind of intense, and there's something about it that settles them and helps them feel real. If they feel dead inside, the act of doing it is sort of a reminder that they exist. So sometimes it gets kind of connected up with that experience. So I want to take a bunch of time to talk about this because I can see that a lot of people here are, with families, and I think the topic of eating disorders is tough and often doesn't, in this population, doesn't always get prioritized. And I think for families, it's tough to know how to switch gears when they start to understand the BPD or they start to understand how they can be helpful in those ways, and they get presented with new information about burgeoning other symptoms like eating disorder symptoms. They have to retool and quickly understand how can I be most helpful now? What's different or what's changed? Talking about feelings and not food is just always a good idea. I think getting into the language of double meaning when you're talking about food gets to be a mess, and people get anxious about their family member, and instead of saying, I'm worried about you, you look like you're not doing well, they might start asking about, did you eat today? Did you do this today? And it's actually mostly a translation, if they really thought about it, to, you don't look well. I don't know if you're well. Are you okay? It's better to just ask that question. How are you feeling? Offering support but not trying to take over. This is a big one. When you're worried about a loved one, it's really easy to want to take over when they're doing dangerous things, or in this case of eating disorders, maybe things that will, get them in a medically compromised position. It's tempting to take over. It doesn't work. There's a lot of ambivalence around giving up these behaviors. And the readiness to change data, which I'm sure if you guys have learned about BPD, is very important. It's very important. So looking at where people are on the continuum of readiness, are they kind of in a pre-contemplative place where they're thinking about change but not really enacting it yet? They're looking at a pros and cons list, the pros of having their eating disorder and the cons. What's going to happen to my treatment if this gets worse? Am I going to derail my BPD work and have to go over and do an inpatient stay for my anorexia? These are things that come up, but they have to sort of stay in that place of ambivalence and really work through moving along the continuum of readiness. And it's often a slow process. And so for patients, that's probably the biggest recommendation for families to have patience with that process of seeing enough cons, feeling enough cons, and enough consequences to decide it's time to change this behavior and really get serious about it, not just think about it or talk about it. Being curious rather than judgmental, this is huge. Because you're anxious about a friend or a family member, it's very easy to just get into a judgmental place out of anxiety. But it doesn't work. It's much more useful, I think, to be curious about the behavior with them. Why do you think this is happening? What do you think that means? What does it do for you when you do that? These are hard conversations to have. Their therapist, I'm sure, is having it with them, but it's also a good idea, I think, for families to get in the habit of asking those questions too. Why do you think you did it? And it's sort of like playing catch, and you're being curious with them. It's like you're tossing the ball back and they're thinking about it, giving it back to you. But if you just let your anxiety kind of run the show, and you can just sort of take too much responsibility on and get into a place of judgment. Don't clue with the eating disorder. So this is, you're going out to dinner and your friend or spouse or whoever has the eating disorder starts making new rules about this. We can only go to these 2 restaurants. If I can't see the menu first, we're not going. I need 3 hours to eat that meal. That's a restaurant that has high turnover of tables, so I'm not going in there. Colluding with it is to say yes to all of this, to allow the avoidance to kind of build up, and usually it just builds up anger in the family system, and it typically doesn't help the person do any exposure. So I would say trying to work with the person's therapist to understand how not to do that, and to set some limits that feel like just normal eating for you, and to be supportive, to eat with the person if that's supportive, but to not engage in looking up calories for them and all this other stuff that can come up. Ambivalence is a normal part of recovery. I've talked about that a lot. You can't force the change, and it's often a slow process, and it's hard to be curious in that space, but it's very important. Avoiding comments about body shape and weight. In particular, it's probably really obvious to not say negative things, but it may not be as obvious that saying positive comments can also tip off bad feelings. So you look really good today might mean you didn't look good last week, or you look really healthy might mean oh, I've gained weight, and that now I don't think that means I look healthy, it means I look fat. And so it can be a cascade. It's much better to not do the trap of reassurance seeking also if somebody asks you, do I look fat in this? Do I look good in this? Do I, to really not engage in those conversations, to instead say, I feel like what you're asking me is, is someone going to care about me if I look this way? Or, trying to get behind what that question is about, because that's a trap and it doesn't work. So if you say you look beautiful, you look gorgeous, don't worry about it, it means nothing. And typically it's just an endless process where family members or spouses or friends can get really frustrated because they feel pressed by the reassurance seeking, and it doesn't actually do much. Getting support for yourself is really important. I think the anxiety that comes with the lack of control you have if you're watching a family member really struggling with an eating disorder is critical, because it's frustrating, it's anxiety-provoking, it's a lot of things. And I think when people don't get help, they just act it out with the person who's ill, and it never makes things better. It just makes things more complicated. So that becomes really important. Massachusetts Meta, which they just changed their name to Multi-Surface Eating Disorder Association, they're great support right in Newton. They have some free talks you can go to, and families get together and exchange phone numbers and get support. It's a big deal. An organization like this is about supporting families too. And I think when the treatment changes direction, if the eating disorder has to be the focus for a little while, sometimes families do feel burdened if they don't have a community to talk to about what's going on. So that's, I think, most of what I wanted to say. What about questions? I left a couple of things out. Like I said, I didn't talk about levels of care for eating disorders, which I can do. But I think it's probably more interesting to think about what you guys want to hear that maybe you haven't, or is there any questions that come from hearing about all this? Right. So sometimes if that becomes a habit and it's like a dance you're doing and you both know it, usually the most useful thing is to have a therapist help you or have someone mediate it. It doesn't always have to be a therapist. Sometimes it's another sibling in the family can sort of say, hey, what's going on here? But lots of times the therapist is the best bet to find a new communication. And it doesn't mean they get to know everything and they get to be completely intrusive. It just means we have to have a language when we see things happening, or we worry about what you care. How will you let us know if we can be helpful? So a lot of times it's just figuring out with your therapist, what's the language? What's our signal? Wink, wink. And that families can do that really well once they have some skills and once they have some direction. But with no direction, the anxiety just starts to build and build. And then sometimes it does feel intrusive when they come to you. But really good question. Yeah, so like I said, a lot of the research in the eating disorders community, screens out folks with personality disorders. There's been some interesting, and also I should say, I didn't say this, but so cluster B, which BPD is in, there's also a bunch of research obviously on anorexia at cluster C and some things cluster A. So there's other stuff going on, but I think the one thing that's been very true since DBT came along and interpersonal therapy got some trials and some sort of meat on its bones, I think people are much more accepting that this treatment has to be more relational, and that without that, it's going to fail. It's a crux of the BPD diagnosis, so it makes perfect sense that CBT would not have worked if you're not allowed to talk about what's going on with you and your therapist. So the eating disorder research community is different than the eating disorder treatment community, because a lot of times the researchers, this is really tough because they can't separate out the variables. Well, this person's depressed, and they've got anxiety, and they've got a family history of both of those things, and now they have an eating disorder, and they have BPD. So it's hard for them to understand their outcomes, right? Their findings. And so you could see why they try to pare down these groups. But then the data they give us means nothing to the treatment community. So, but again, I think Marshall Linehan and DBT has really, the fact that DBT is now getting applied to so many different treatments, that's really helped because the outcomes are much better for the eating disorder community. So This is a tough one, because if you've had, I don't know how frank the conversations are that you've had, but if they were frank, you might be able to talk about, like, gosh, am I participating in something that's not going to be great for you? Or how is this going to go at the house if you're struggling with this? Is this, I don't know that she wants to change it. So binge eating disorder, I don't know, one of the criteria up there is that there's distress about the eating. And so that leaves out a bunch of people who are eating a certain way, and really their family members are distressed about it, or other people, their healthcare providers are very distressed about it, but they themselves are not distressed about it. That's really a different story, because it's harder to engage. But if I don't know if it's somebody who's talked to you about her own concern or her own guilt or her own displeasure with the situation. Has she done that? Mm-hmm. So there's not a huge volume of stuff sitting around. Yeah, I mean, you can also say too, I know we've talked about that this is a huge comfort for you. Is there another way I can help you feel comfortable at my house? I mean, what kind of, thinking about, basically you're acknowledging the need is reasonable, that you want to be, that you need comfort, but I would wonder if, what kind of flowers do you like? What music, asking about other things that would represent a comfortable environment. Can you come with me? We'll take a walk with the dogs. Something that sort of engages the need, which is, I get it. You might be in distress at my house, but for you to ask me to solve it this way with you makes me feel terrible, because we've talked so much about how much you hate this. It's hard to, engage in it. So I would probably go that route, just with a lot of compassion. And it may be a setup. She may be wanting you to do that. She may have asked you to get the candies so that you would come in and be concerned and say, this sounds concerning. It may have been a signal, like a cry for help. Can you go get me the candies that I binge on? Yes, I'm so glad you brought that up, because I think I axed a slide that was about that. So now I can talk about it. It's very common in the course of recovery to have people slip into different categories. So a very common occurrence is somebody that has sort of a restricting anorexic to start gaining some weight back through treatment, through good treatment, and then move into a position of secretly binging and purging and not telling anybody, and then moving into the diagnostic category of doing it more often, and people see what's going on. And so you do see people change categories, and they may also switch their compensatory behavior. So you may have somebody with bulimia who used to purge and got that behavior under control, but then started compulsively running after meals, and it sort of looks. So you just see movement. You also see people who will say that are overweight or obese and in the binge eating disorder category, that they have been at different points in their life, different places. The hallmark difference is, people who have binge eating disorder, I didn't have this on the slide, a lot of them have dieted, over the years and had pretty negative experiences of not, just not good experiences. And so they will say, yeah, I've had disordered eating all my life. I've been numbing out all my life. I numbed out when I restricted. I numbed out when I binged and purged. I numbed out overweight. And, so sometimes there is that sort of graduation of symptoms, so they're not in a medical unit anymore with a tube down their throat, but they're still struggling with their relationship with food. So it's very common for people to kind of bounce around. One thing that's interesting is, another thing that's more common is, again, people who use those compensatory behaviors, there are more of them in the BPD category. And so if we looked at like avoidant personality disorder, if we looked at dependent personality disorder, if we looked at some of the others that correlate highly with anorexia, for example, we might not see as much crossover in those folks. But people that have other impulse control problems, there's a whole bunch of crossover for them. So we see more of that movement with certain folks. But yes, it's very, very common. And that's why when people complain about, in an eating disorder group, mixing up, I don't want to be in this group because I'm an anorexic and she's bulimic and we don't have anything in common. That's often the line of sort of course you do. You both have a sort of disordered relationship with food. It's taking over your life and it's hurting your functioning, and you have a lot in common. Well, the degree, for sure, because most people in the BPD category have, long before it gets tagged or treated, they've had something going on for years, so that's part of the problem. But when we look at these pure cases, who are they that respond well to 20 or 25 sessions to CBT? Typically, they're people that picked up the behavior from a friend or in a sorority, or because they were in college for the first time and the level of academics got a little tougher. And
more habit
you got it. And also that they may have picked it up at 21 or 19, not 13 or 14. And that when they, as soon as they learn some of the sort of negative parts of it, which CBT does a really good job of sort of psychoeducation around what is it going to, if you're vomiting, what does it do to your teeth and what does it do to this, that some of that education is enough, and some of that awareness, oh, you're going to give me a tool on how to manage that school stress before the test? Got it. I don't need to use that anymore. So when you see that real quick 20, 25 session turnaround in symptoms, that's the kind of patient that's in the research study, typically. I'm trying to think of another good example. Another good example would be people that have depression or anxiety, no personality disorder diagnosis, and dip into the behavior for a brief period of time. So a very typical example of that are no appetite with depression, no real interest in food, not doing good self-care in general, and so who cares? I'll eat, I won't eat, I don't really care. And they drop some weight, and they say, oh, well, that's an interesting byproduct of my depression. I wasn't trying to, it wasn't because I thought I was fat, but they experience the weight loss, and then they decide, oh, I'm better, my depression's better, and I gain the weight back because I'm eating normally again. How can I get that weight off again? And they go back to following the model that happened sort of by accident through depression. There are a bunch of those people, so that when they get really good education on weight maintenance and really good nutritional education for the first time, a lot of the symptoms kind of go away. Right, and there's more dysregulation to manage, so there's that, and then there's also the relational context, that the symptoms have meaning in relationships, and that sometimes that is reinforcing. If you're having trouble communicating in your relationship directly, it becomes a vehicle of communication. So that's in the mix as well. So if conflict avoidance is there, assertiveness problems are there, you want to please people, you want to be liked, it's very hard to communicate directly. So this ends up being a vehicle for that too. Oh yeah, no, the numbers I had up before are pretty high, 16 to 33%. That's you look at that overlap of when they co-occur, it's pretty high. And the more impulse control problems someone has within the category, you imagine they may be more susceptible. The more, if they have an OCD variant as part of what they're dealing with, and they have a lot of, compulsion is sort of an issue, they're going to be susceptible too. So, because the behavior does get compulsive. So there's a ton of overlap, and that's why we're here talking about it, because I think a lot of times what makes me I said I would talk about this before we finish up, but in terms of treatment, what do you need to be looking for if you have both of these things going on? You need to have a clinician who knows how to assess if we're getting into a situation where the eating disorder has to get bumped up in its treatment priority because there's sort of things going on with sleep, or things going on with blood pressure, or things going on, with medication not being able to work, that the weight gets low enough. You have to be with someone who's going to tag that stuff and not just say, it's more of this. It's all in the same category. It's just others, I think it can be understood as a self-injurious behavior, and it should be, but I think it becomes important to talk about, well, when should we assess and do more about it? When does it have to trump this problem? When can it be just pushed back in the category with everything else? When do we have to separate it out? And the consultations that I do around the hospital and around other hospitals in Boston are often about that. We don't want to distract the treatment. The BPD treatment is going well. We don't want to distract with this. Is this a good idea to put this person at a higher level of care? And we have to evaluate, is there enough going on with this that it's becoming, for the brain, a problem, and we have to do something about it. So I think it's important to have that in the treatment, and if it doesn't mean that your therapist has to be an eating disorder expert, they just have to be willing to consult if they're concerned about any symptoms now branching out in a way that's really hurting your functioning to a different degree. So, yeah.
Can you talk about the sleep disturbance part?
Yes, so restriction in particular will do this. And so you've probably heard the stories of anorexic women who die in their sleep, or who have a really low pulse and, end up, not knowing when they go to bed that that's going to be it. That really comes from the body is not really able to regulate a bunch of things when you start restricting food. When you start restricting fluids, it's even worse. But basically impacts your sleep and keeps you awake. It's sort of almost imploring you to go get something to eat. It's very hard to fall asleep. Has anyone tried to fall asleep when you're starving? It's actually very hard to do. The body kind of knows what it's doing. So when you start to do that, you can end up with these sleep-wake cycles that get really out of whack. So people start losing a lot of sleep. And a lot of treaters assume it's anxiety because that's often present too. But if there's enough restriction, that starts to happen on its own. And then you get a chicken or the egg phenomenon with depression and anxiety. What's causing what? The dopamine levels, the serotonin levels. If things are shifting, is it because the person's restricting now? Is that causing more depression and anxiety? There's a lot of literature, and same with the sleep disturbance. Is it their depression? Or is it they're restricting so much that their body is imploring them, they're staying awake, and that's tipping off more depressive symptoms? So sleep dysregulation is a big one to know when you're assessing it, that you're not just looking for how does this relate to bipolar, or how does this relate to depression, or how does this relate to anxiety, but also how does this relate to the eating disorder? Yeah, and it's very, very common. So we actually one of the things we learned from the studies of people the early studies where we induced these starvation states in people, they were all staying up all night. So that we've seen this with people that have no history of anorexia, but for the purpose of a research study, were put on a very limited calorie diet to sort of watch what happens in these semi-starvation states, and that was one of the things that started to happen. We couldn't sleep. Yeah. So you're in a situation where you're not hungry at all, but feel a psychological need to binge. Yeah, so riding the wave, of course, is important, because one of these things that makes you feel like I've got to go do this behavior like an automaton is the lack of ability to sit with the discomfort, right? And that discomfort is usually about a whole bunch of other things. And the sooner you can make meaning of that, the better, because when you are trying to delay or distract or any of those sort of behavioral strategies, it's really helpful to know if you can go to what am I really hungry for right now? What is happening that this feels like such a press? I'm not hungry. Where is this urge coming from? And sometimes journaling about that can take you away from food and into, I'm hungry for comfort because it's nighttime and I'm by myself. Or I am, hungry to be filled up, and why do I want to be filled up? Filled up with what? What's happening? So sometimes journaling in moments like that, also doing it in a place you have no access to food, by the way, right? Don't do this at Starbucks. I had someone telling me about that the other day. I'm like, it's not where I want to do this. But trying to sort that out can be helpful because you're basically telling yourself, this is much more meaningful than food. This is much bigger than food. I've realized I'm not hungry right now, and I've decided that the discomfort, I can live with it. I can live through this discomfort. It's not going to kill me. I'm going to be wildly uncomfortable. Now I'm going to write for a half an hour about why I am so uncomfortable right now, why this feels, But we do have just to give you some data on what's happening in that moment. So these dopamine receptors that really kind of contribute to goal-directed behavior, go get that food, go get that drug, go any of those kind of presses. When people get really good treatment and they stop doing, say, binge behavior or whatever, we see some of those receptors pair back. So sort of a lot of them that get assigned to habitual foods that you binge on. So it does we thought this only happened with, cocaine and other, but we know it happens now in the same way. And so part of the treatment is when you can, it's sometimes a really good motivator for people to decrease their binge episodes because they know that they're changing their brain. They're literally having more tolerance, and that discomfort shifts over time. Same thing with sobriety. People talk about this all the time in the rooms. They talk about how uncomfortable it is initially. Over time, it's a little bit easier. You get more associations. You pass a bar you used to go to, whatever. It's very hard the first time. It's a little bit better. It's and over time, you build up a sort of tolerance for it. Now we know that sort of things are changing in the brain when that's happening. And by the way, there's this 30-day period that looks to be relevant. You know, it sort of matches up with 30-day substance abuse treatments, but it seems as though things start to shift around that point if you change your behaviors and you take away some of the compulsive stuff, you don't do it. Things start to shift in the brain. So there's actually some legs behind that feeling too, but it doesn't mean you can't change it or sit through it. It's just getting used to sitting with that kind of discomfort. Yes, so there are a couple of really good books, and if anybody Googles this, this is sort of a hot topic right now because Dr. Kessler wrote a good book about this, so check out his name. But anyway, so the idea is in trying to understand these behaviors beyond the psychological urge, which we know is sometimes about wanting, you know, comfort or any of these other things. We want to understand what's happening in the brain. And for years, this research was being done with addiction, you know, so what's happening for heroin addicts, what's happening for when they get exposed to a needle, or they get exposed to a reminder of wanting to do this behavior, what gets activated. And so this goal-directed behavior of go do the thing that feels like such a press for people when they're trying to break out of a compulsive pattern has some brain legs to it. And so they're really trying to understand these relationships to understand why now, of course, why people are doing this with food. Because there's always this question is, you know, I'm addicted to food, I'm addicted to sugar, I'm addicted to the, you know, and the science behind what is happening when people eat certain foods and they feel they have to have more of it and they have to have it again is spurring on this research to sort of understand what the role is. So there's a lot more, I could get into a lot more, but I think it's a really cool area. It's not all out yet, but suffice it to say that I think we're going to find that the dopamine receptors pair back and change as people change the behavior around this, the goal-directed behavior to go get the food in particular. Quiets down. The idea is that the brain changes with the habits. So if you go and on cue, every time you start, I don't know, binging on a certain food, ice cream, and you start getting the associations that this is what I do at 6 o'clock every night. Go get the ice cream and I binge. I go get the ice cream and I binge. This is my regulatory mechanism. This is my finisher. This is the end of my day. You start telling yourself that, and you start acting behaviorally in accordance pretty routinely, once a week, twice a week, 4 times a week, that something's shifting in the brain when you think about going to get the food. That all these receptors get right behind it and say, yes, you need to go do that. Yeah, it's much more understood in Tourette's though. I think this is just this much of what, you know, learning about it is much, it's much better understood. But I think we'll get there, I do. I think we're gonna come out of this addictions model with, and look at, well, anyway. Suffice it to say, check it out. I think there's more coming. A lot of this is preliminary, but I think it's really interesting stuff. Well, yeah, but now we have behind it that if we look at these receptors and the number of them assigned to a certain thing, that they change in a certain way, pairing back. So now we used to just say that and know that it takes a while to change, which is nice. But now we're actually, if we can actually measure this and see these pairing back over a 30-day period, and that has something to do with why you can walk by the Starbucks and not go in and get the donuts and the binge, and why the first day you did it, it felt like, oh God, I just why is that? What shifts? What's happening in the brain when you have those 2 different experiences? Or you stop, salivating and having all these other physiological markers. It's very interesting. Well, thank you all. Appreciate you coming tonight. And my email's up there if anybody needs me for a question that I didn't answer. But in the meantime, I'm glad you can all come and think about this together. I think it's really important to have these treatments come together and tailor the treatment so that both pieces get addressed, and that there's enough support in the relationship to really make room for both of them. So, thank you.